Good evening, everyone. I am Dr. Viswa Theja. I am the Consultant Emergency Medicine at Yashoda Hospital, Hitec City Branch, Hyderabad. I welcome you all to weekly webinar hosted by Emergency Department at Yashoda Hospitals, Hyderabad, under leadership of Dr. Srinath sir. For today's topic, we have traumatic shock. Usually, the kind of shock we get in trauma cases is usually hemorrhagic shock. But other types of shock can also be seen, encountered in such situations like distributive, obstructive, and cardiogenic shock. And especially in certain elderly users, we can see cardiogenic shock in trauma victims. Being an emergency physician, we should be aware of all these things, and we should have a holistic approach to deal with such kind of patients. To present the topic in detail, I have here with me Dr. Amareswar Reddy. He's a consultant emergency medicine at Velammal Medical College Hospital, Madurai. Sir, over to you. You can take over.
Hello, good evening, everyone.
Good evening, sir.
Can we start? Are we having all the participants ready?
Yes,
Yes,
they
sir.
won't be able to speak. They can post their questions in the QA section or chat section.
Okay.
You can start sharing your screen share.
So let's start today's topic, traumatic shock. As Dr. Vishwa told, traumatic shock is one condition which will significantly increase the morbidity of these trauma patients. You know, India has a lot of road traffic accidents every year, and we can literally see a lot of tsunamis happening on Indian roads every year. And as the road infra is developing year by year and number of vehicles coming on the roads, year by year, the number of road traffic accidents are increasing, road traffic mortalities are increasing, in spite of increasing safety norms on the roads. So we as emergency physicians should be equipped with, should be upgraded with our knowledge, should be well equipped with our infrastructure in our departments to save these patients. So let's start this topic. The first step in managing a shock in trauma patient is to recognize its presence. Yes, it is very important to recognize the shock first in place.
Can you?
Am I audible, sir?
Yes, but your screen is not on full screen mode. Can you go to presentation mode?
Yes, sir. I can see it in full screen, but
the screen that you have shared is the small one.
Yes, sir. So where should I make these settings?
You can click the slide share option, sir.
Just click stop sharing and reshare with full screen. Share the entire screen instead of one window.
Stop sharing. Okay. Hello. Sorry for that brief interruption. So the first step in managing shock in trauma patients is to recognize its presence. Okay, the objectives, these are the objectives of today's talk. Yeah, the definition, by definition, the shock is an abnormality of circulatory system that results in inadequate organ perfusion and tissue oxygenation. Diagnosing shock in a trauma patient relies on a synthesis of clinical findings and laboratory tests, and no single vital sign and no laboratory test on its own can definitively diagnose shock. Yes, you cannot blindly rely on a blood pressure. You cannot blindly rely on a heart rate or a single parameter to diagnose shock. It is a synthesis of various clinical findings and laboratory tests.
Is there any connection issue, sir?
No, it's not a connection issue. There was some problem with changing the slides. Okay, I think it got rectified. So any injured patient who is cool to touch and is tachycardic should be considered to be in shock until proven otherwise. Again, I have the same issue.
Okay, sir, I'll change the slides. You just let me know. Please unmute yourself.
Yeah. Okay. So the first step is to identify what's the probable cause of shock in a trauma patient. Because technically any kind of shock is possible in a trauma patient. Next slide, sir. And shock in trauma patient can be widely classified as hemorrhagic shock and non-hemorrhagic shock. The non-hemorrhagic cause of shock are obstructive shock, distributive shock, and cardiogenic shock. The cause of obstructive shock are tension pneumothorax, cardiac tamponade. Distributive shock is possible because of neurogenic shock because of spinal cord injury, or in late presentation, it can be because of septic shock also. Cardiogenic shock, it can be because of myocardial contusion or because of even acute coronary syndrome during trauma. Next slide, sir. In hemorrhagic shock, there is loss of circulatory volume. Okay, so it is hypovolemic shock. So definitely control of hemorrhage and restoration of adequate circulating volume are the goals of treating hemorrhagic shock. Next slide, sir. Whereas in tension pneumothorax, there is abnormal accumulation of excessive air, too much of air in the one hemithorax, compressing on the lung and causing significant pressure on the mediastinum and the heart, causing an obstruction of blood flow into and out of the heart, causing a severe obstructive shock. And this is a severe life-threatening emergency which can kill the patient within seconds to minutes. Next slide. So, as usual, as emergency physicians, we all know how to decompress a tension pneumothorax. It needs to be initially, as soon as you identify a tension pneumothorax, you should put a needle in the second intercostal space in the mid-clavicular line or in the fifth intercostal space in the mid-axillary, just anterior to the mid-axillary line to decompress it. Soon after that, we should place a ICD. Next slide, sir. And cardiac tamponade. It is identified by Beck's triad, a distended neck pains, muffled heart sounds, and low blood pressure. So, in cardiac tamponade in trauma patient can be caused by as little as 50 ml of pericardial fluid. Sudden accumulation of this pericardial fluid because of injury to the myocardium or coronary vessel can cause significant pressure on the right ventricle and collapse of the right ventricle, causing severe right ventricular diastolic dysfunction and severe obstructive shock. Even this condition can kill the patient within a few minutes. So this has to be treated by pericardiocentesis. That can be best done under ultrasound guidance. Next slide, sir. Again, next slide, sir. And then coming to neurogenic shock, it is because of injury to the cervical and upper thoracic vertebral injury causing spinal cord trauma. This will cause, next slide, sir. This will cause loss of peripheral sympathetic tone and peripheral pooling of blood, causing relative hypovolemia. And the patients will have a wide pulse pressure, low blood pressure, and the heart rate will be low. And this is treated by crystalloid resuscitation, 1 to 2 liters of normal saline and Ringer's lactate. The patient is not responding with these fluids. Start the patient on peripheral vasopressor like phenylephrine or noradrenaline. Next slide. Septic shock. The patients who present late after trauma can present with septic shock, even though this is where we should keep this in mind in trauma patients. And some elderly patients who have sustained injuries at home, okay, like a syncope and fall at home, might be having fever and sepsis, because of which the trauma would have happened. So we should keep that in mind. So as usual, here we have to treat with fluid resuscitation, blood culture, early antibiotics, vasopressors, and inotropes when required. Next slide, sir. Cardiogenic shock. Cardiogenic shock also can occur in trauma patients because, as you know, the acute coronary syndrome can happen to anyone at any time. Even the trauma patients, the acute coronary syndrome can occur. Myocardial contusion because of blunt chest trauma can cause arrhythmias and cardiogenic shock. Next slide. Hemorrhage. It's always hemorrhage. We should keep in mind in trauma patients. Any trauma patient found to be in shock is bleeding somewhere until proven otherwise. Next slide. So coming to the basic cardiac physiology, the cardiac output is heart rate into stroke volume. The stroke volume is generated by preload, myocardial contractility, and afterload. Preload again is dependent on, next slide, sir. The stroke volume. The stroke volume is the amount of blood that leaves the heart with each cardiac contraction, and it is dependent on the preload, myocardial contractility, and afterload. Next slide. Preload is nothing but the volume of venous returning to the left and right side of the heart. Myocardial contractility is well defined by the Frank-Starling's law. This says that more the cardiac filling and more the stretch of the myocardial fiber stretch, the force of contraction depends on the stretch of the myocardial fibers. So after load, the peripheral vascular resistance is systemic in systemic circulation. Simply stated, after load is resistance to forward flow of blood, and this will increase the diastolic blood pressure. Next slide. So what are the compensatory responses to shock? The baroreceptors sense decreased stretch. Chemoreceptors detect increased carbon dioxide and decreased pH. Sympathetic nervous system is activated by these responses. Adrenal glands release catecholamines, epinephrine or norepinephrine, causing peripheral vasoconstriction, increasing the diastolic blood pressure. Next slide. So these are the stages in shock. Okay. In the stage 1, the compensated stage, and stage 2, there is a decompensated state where the patient will progressively develop hypotension and worsen. And in the stage T, the patient will irreversibly in a shock state. How much ever you treat, the patient, the shock cannot be reversed. Next slide. At the early stage, the cells are deprived of oxygen, anaerobic metabolism is started, lactic acid formation and metabolic acidosis is formed. Later on, if the shock is prolonged, end-organ damage, multi-organ dysfunction results. Next slide. So, approach to trauma. Is it ABC or CAB? Okay, in the pre-hospital scenario, we should always keep CAB in mind, because in the pre-hospital scenario, you should, as soon as a trauma patient is looked at, you should see what is the mechanism of injury. Is the patient bleeding very heavily to death? Okay, if the patient is bleeding very heavily, first you go to the place where the patient is bleeding. If the patient is had amputation of the limb and severely exsanguinating from there, you should immediately apply a tight tourniquet to stop bleeding and then go to the airway and breathing. Okay, whereas in hospital where you have adequate team, even though you see the patient bleeding somewhere, okay, one of the team members should go to the airway, the others will go to the circulation part. That is, somebody will secure the IV access, somebody will take measures to stop the bleed. Next slide. The bleeding trauma patient. In early hemorrhagic shock, the venous return is preserved to some degree by compensatory mechanisms of contraction of volume of blood in the venous system. The venous system is the capacitance system. It is holding a lot of blood. So when the blood is lost, okay, some degree of compensatory mechanism will contract the venous system and bring that into the main circulation. This compensatory mechanism is very limited. Okay, next slide. Okay, so as soon as we suspect bleed somewhere, we have to stop bleed. Okay, suppose the patient is suspected to have pelvic fracture. The pelvic compression and distraction test is doubtful. As soon as any doubt is there, we should apply a pelvic binder. Okay, or I can tell any patient presenting to emergency department in shock, you can apply a pelvic binder, because pelvic binder application is not going to cause any harm to the patient. Okay, and followed by there should be definitive control of hemorrhage and restoration of adequate circulating volume are the goals of treating hemorrhagic shock. So as you are restoring the circulating volume, you should also have the goal to stop the hemorrhage. Okay. Next slide. So to restore the circulating volume, we should have a 2 wide bore peripheral vascular accesses. A lot of emergency physicians, a lot of residents have doubt in their mind. Why we can't go ahead with central line? Okay. If suppose the patient is presenting to emergency department in a shock state. In a shock state, peripheral IV access is not possible. Okay, then they will jump to put a central line. Okay, because it is not that putting central line is not easy. Okay, it might be easy, but when you see the central lines are very long. Okay, as per the Hagen-Poiseuille's equation, the flow is directly related to 4 to the power of radius of the cannula, and it is inversely related to the length of the cannula. Okay, if you take the peripheral IV cannulas, the length of the cannula is short, and the as we are securing a wide bore one, the flow will be much better. That is, flow will be 4 to the power of radius. Whereas the central line, because of its length, a significant resistance is there, and the flow is very much reduced, even though you put in a pressure bag. Okay. What if the peripheral IV access is not possible? Then you should go for, next slide, sir. then you should go for a IO access. The most preferred IO access in a trauma patient is proximal humerus. Okay, this will make the work very easy. Even though the patient develops cardiac arrest in this scenario, resuscitating the patient will be very easy. So always in a trauma patient, the vascular access or IO access should be above the level of diaphragm. You should not go for femoral access. Okay, next slide, sir. So coming to crystalloids and colloids. Okay, we have these fluids very, very handy in all our emergency departments. Okay, we have normal saline, we have Linger's lactate, we have various colloid solutions. Okay, but what are the drawbacks of these solutions? Okay, so as soon as you find a patient in hypovolemic shock, we'll start the patient with some fluid. Normal saline is very commonly started. Okay, normal saline has plenty of chloride. It has 154 milliequivalents of chloride per liter. When you resuscitate a trauma patient with just normal saline, okay, it will cause hyperchloremic metabolic acidosis. Already these patients have lactic acidosis. If you add more chloride to the patient will also develop non-anion gap metabolic acidosis, which might further worsen the myocardial contractility, and it might cause worsening peripheral vasodilatation also. So better fluid is Ringer's lactate, which is more physiologic solution. And nowadays we get plasma light, which is also which is little bit more better than Ringer's lactate. It has no lactate in it, and we have stereofundin also, right? And coming to colloids, okay, the colloids, the advantage is they stay in the intravascular space for a longer time, but they can cause platelet dysfunction. Okay, both these fluids they will cause, because you should keep in mind that this normal saline or Ringer's lactate or just salt containing solutions, they don't have any oxygen carrying capacity, they don't have any coagulants. Okay, they don't have clotting factors. Okay, so administering plenty of these fluids will cause dilutional coagulopathy, and more of these fluids are stored at room temperature, okay, which can cause hypothermia. Okay, next slide, sir. Blood. Coming to blood, the goal of transfusion is to provide minimum oxygen carrying capacity by giving packed RBCs and sufficient platelets and clotting factors to permit hemostasis. In emergency situation, cross-matching can be skipped. In extreme emergencies, like the patient is received in class 4 hemorrhagic shock, then we can just order O negative packed RBCs in case of female patient. O positive RBCs can be transfused in case of men. Okay, and if O negative is available, then we can offer O negative also in men. But in female patients, definitely it should be O negative, especially of childbearing age group. Okay, next slide, sir. Okay, what is hypotensive resuscitation? Hypotensive resuscitation, also called permissive hypotension, is a resuscitation strategy that uses limited fluids and blood products during early stages of treatment for hemorrhagic shock. A lower than normal blood pressure is maintained until operative control of bleeding can occur. Okay, essentially in emergency department, don't try to achieve a normal blood pressure. A systolic blood pressure of 90 millimeters of mercury is sufficient for a patient without head injury. And if the patient is having head injury with the features of raised ICT, you can achieve up to 100. Okay, and if the patient is also having hypovolemic shock. Okay, next slide, sir. Next. Okay. Okay. In hypotensive resuscitation, allow the systolic blood pressure to fall low enough to avoid exsanguination, but keep high enough to maintain perfusion. This is the goal. The goal is to avoid disruption of an unstable clot. Water clot that has formed naturally of the trauma is a precious clot. Don't try to pop that clot. Next slide, sir. Okay. Low blood pressure is not the target. It is a compromise in pending emergency, surgical intervention. So this low blood pressure is not the target. Only this low blood pressure can be maintained until a surgical control of hemorrhage is achieved. So the patient have to be shifted to operation theater, and surgical control of hemorrhage should be achieved as soon as possible. Okay. So massive transfusion protocol. Coming to massive transfusion protocol, it is defined as more than 10 units of packed RBCs within the first 24 hours of admission, or more than 4 units in the first 1 hour. Okay, early administration of packed RBCs, plasma, and platelets in a balanced ratio, that is 1:1:1, to minimize excessive crystalloid administration may improve the patient's survival. Okay, simultaneous effort should be on to rapidly control the bleeding. Okay, always stopping the bleeding, it should be our goal. Okay. Okay, massive transfusion protocol should be triggered when the patient presents in class 4 hemorrhagic shock, or if the patient haven't responded to your fluids, or the patient have transiently responded to your fluids. Okay, the target is hemodynamic stability and not any hemoglobin number. Next slide. Okay, early surgical intervention or angioembolization is very important in this patient. The presence of shock in a trauma patient warrants immediate involvement of a surgeon. Okay, hemorrhage control is the goal. Once this is achieved, normalization of hemodynamics is appropriate. Next slide. Always prevent hypothermia. Hypothermia is very, very, very detrimental in these patients. These patients who present in shock state and we give plenty of room temperature fluids, they are prone to develop shock. When we intubate these patients, put them on various sedative agents, neuromuscular blocking agents, their thermogeneration will be drastically reduced and they will develop hypothermia within no time. Once the patient is hypothermia, managing these patients will be very, very, very difficult. So keep this in mind to keep the patient, to protect the patient from hypothermia. Okay, always try to administer warm crystalloids, cover the patient in warm blanket as soon as possible, transfuse blood via blood warmer, use body warmer if hypothermic. Hypothermia can worsen coagulopathy, can cause platelet dysfunction and excessive bleeding, and these patients can bleed heavily and the coagulopathy will worsen with this. Okay, so and avoid acidosis. Okay, acidosis inhibits clotting and decreases the myocardial contractility. Ventilate adequately. Okay, in case these patients are put on mechanical ventilation, you should see that the ventilator is properly set so that the minute ventilation is adequately generated. So the target is to maintain the pH below 7.20. Next slide. Okay, calcium. Don't forget calcium as you're administering plenty of blood and blood products. Keep in mind that these blood products contain citrate, and citrate will chelate the calcium, and calcium is very much essential for coagulation. Hypocalcemia, even though the clotting factors are adequately given to the patient might not stop bleeding because of calcium deficiency. So always keep calcium in mind. Next slide. Tranexamic acid. Okay, tranexamic acid competitively inhibits the activation of plasminogen to plasmin. So its benefits in trauma resuscitation is very well defined in TRASH-2 trial. Okay, in the adult dose is 1 gram bolus in 100 ml of normal saline over 10 minutes. Okay, followed by another 1 gram to be infused slowly over next 8 hours. Okay, so tranexamic acid is clearly beneficial when it is administered within 3 hours, only within 3 hours of trauma. Okay, next slide, sir. Coming to some words about the TRASH-2 trial. This trial was a randomized placebo-controlled trial, and it was conducted in 274 hospitals in 40 countries, and almost 20,211 patients were enrolled. The patients were randomized to receive either tranexamic acid, as told earlier, or a placebo, or either a group, or half of the patients received tranexamic acid and half of them have received placebo. Next slide, sir. And it have clearly demonstrated that tranexamic acid was associated with a 1.5% absolute reduction in mortality. Okay, tranexamic acid was associated with a 1.7% absolute reduction in need for blood transfusion, and there was no difference in the risk of vascular occlusive events. So the thrombosis is not increased because of administration of tranexamic acid. So don't think that tranexamic acid will cause increased coagulation and it might cause some events in these trauma patients. So because there is no difference in risk of vascular occlusive events in both these groups. Next. Okay, coming to the role of elastogram. Okay, thromboelastogram thromboelastogram is a study where it will assess the nature of clot formation, how fast the clot is forming, what is the nature of clot that is formed. Okay, and it can detect where is the deficiency in clotting mechanism, whether it is because of the platelet dysfunction, whether it is because of the coagulation abnormality, what is the coagulation abnormality, whether it is because of the clotting factors, whether it is because of the deficiency in fibrogen, So it will exactly give what the information regarding the clotting problem, and accordingly we can tailor our therapy. Okay, if the patient requires cryopress plate, we can administer cryopress plate alone. If the patient requires fresh frozen plasma, we can administer fresh frozen plasma, or any selective clotting factors can be administered rather than broadly giving fresh frozen plasma and platelets alone. Okay, next slide, sir. So always keep the comorbid patients in your mind. Okay, any elderly patients coming to your ER having a normal blood pressure, from the 120/70 blood pressure, a heart rate of 80/84 might not be normal. The patient might be in a shock state, because many of these elderly patients might be having coexisting conditions like hypertension, chronic kidney disease, might be taking beta blockers, calcium channel blockers, might be on some pacemaker. So we should thoroughly get a ample history in our secondary survey. Okay, this is very, very important. Next slide, sir. So always keep the lethal triad. Okay, as I told, hypothermia. Hypothermia will worsen the coagulopathy, and coagulopathy will cause worsening of shock and acidosis, and acidosis will worsen the coagulopathy and prompting us to administer more fluids and more blood and blood products, worsening hypothermia. And this is a lethal triad. Once it is ensured, okay, the patient's mortality is multifold increased. Okay, so we should always protect the patient from hypothermia. That is the one thing what we can do in the emergency department. Okay, next slide. Okay, in summary, shock is a mismatch between the supply and demand of oxygen and nutrients. Hemorrhagic shock is the most common preventable cause of death in trauma patients. Early recognition and goal-directed therapy leads to optimal outcomes. Next slide. So next slide. Okay, apply pelvic binder whenever you are suspicion of a pelvic injury or the patient presents in a shock state. Okay, applying pelvic binder is not going to cause any harm to the patient. Okay, prevent hypothermia. Okay, or treat it early. As soon as you find the patient hypothermia, cover the patient in warm blankets. Okay. Transfusion is for hemodynamic stability and not to normalize hemoglobin. Next slide. Okay. Hypotensive resuscitation is only for volatile hemorrhage control. It is not that you keep the patient hypotension for very long time in ER. We should call these appropriate surgeons and shift the patient to operation theater for hemorrhage control. Hemorrhage control is the goal, and achieve it fast. Okay. Elderly patients might not exhibit tachycardia. Blood pressure may be normal. So we should keep in mind, and we should approach these patients appropriately. Always use the ultrasound machine in your department generously. Okay, ultrasound is the investigation which you can do many number of times on a single patient. Okay, it is safe even in pregnant patients. Okay, thank you.
Thank you, sir. It was a really detailed presentation from your side. Okay, even though we had some technical glitches in the starting of the presentation, it was a really good presentation. From my side, I want to summarize the topic. When you see a trauma case as an emergency physician, you have to go according to ATLS protocol. Okay, see blood on the floor and 4 more. Okay, identify the cause. Even though usual shock we see in trauma is hemorrhagic shock, we have to think about other kind of shocks like distributive shock. We have to think about obstructive shock. We have to think about tension pneumothorax. And in elderly patients, even though they don't mount tachycardia and hypertension, okay, even the normal BP, we have to think about other causes. The patient may be on long-standing beta blockers. Okay, that's why traumatic shock, we have to have a holistic approach in dealing, especially in elderly patients. Okay, and once you identify the shock, put in wide bore IV cannulas, give the fluids, and start massive transfusion protocol and deal accordingly. That's what I want to summarize from my side, sir.
Yes, thank you, Vishwa.
Sir. Now we open the panel for discussion. Any questions from the attendees?
Can I see the questions in the chat box?
Yeah, we have a question in Q&A, sir.
Yes, sir.
Yes. Sir, if there is any object.
Yes, sir. Yes, I got it. If there is an impaled foreign body, removing it in ER is not advisable. Okay, we should call the appropriate surgeon. Okay, it depends on the body part where it is pierced. Okay, we should call the appropriate surgeon, discuss with him. Okay, it's better to remove it in a controlled environment like operation theater rather than in the ER. Okay. Spinal shock. Okay. Spinal shock is different from neurogenic shock. It is the transient weakness of limbs. Okay, which is expected to spontaneously reverse. It is
the name will mislead us. It's not related to blood pressure or circulatory system.
Can we use tranexamic acid irrespective of the time of incident? Tranexamic acid is demonstrated to be beneficial in the CRASH 2 trial when it is administered before 3 hours, within 3 hours of trauma. Okay, that's what the CRASH 2 trial says. But I don't think there is any harm of administering tranexamic acid even beyond that. If there is no active bleeding, then no need to give pause. I don't get it. Then no need to give pause right now, sir. What do you mean? I don't get it. If there is no active bleeding, then no need to give. I don't get the question.
I think he meant to say Tranexa.
No, if there is no evidence of active bleeding, then there is no point in giving tranexamic acid. Can we start infusion of tranexamic acid after 3 hours? Yes. If your patient is still bleeding and is in a shock state, you can administer tranexamic acid. I don't think it is going to cause any big problem. Okay, what about vitamin K in trauma? Yes, I forgot to speak about the anticoagulants. Some of these patients might be on some oral anticoagulant, like warfarin. If your patient is on warfarin, then vitamin K have to be given to reverse vitamin K has to be given, and fresh frozen plasma or prothrombin factor concentrates. So all these things will be helpful in that situation. And some other anticoagulants have their own reversing agents, like dabigatran has idarucizumab. Okay. Any other question?
I think there are no more questions.
No more questions.
Vishwa, we can end. See.
Yeah,
Okay.
yes, since there are no more questions, I think we can wrap
up.
up. I think we can wrap up the session, sir. It was nice interacting with you. Being a Telugu person, I had a nice chat with you the other day. I hope we'll continue the same. And we have furthermore seminars on trauma in the following days, sir.
Yeah. Thank you, Srinath sir, who is our inspirational leader. The whole emergency team of Yashoda Hospital, Dr. Naveen, Dr. Kiran, Dr. Ranjit, Dr. Viswa. Thank you everyone for this great opportunity. And I think now we are getting one question. In pre-hospital, sir, how much fluid we can give? Yeah, in the pre-hospital scenario, can I answer, sir? I think everyone is there. Okay, in the pre-hospital scenario, it is not advisable to give too much of fluids. Okay. It is in the giving plenty of crystalloids is not advisable in the pre-hospital scenario. Okay. It's always there's something called don't stay and play. Okay, it is better to scoop and run to the hospital. What are the scope of further studies in traumatic shock? What are the scope of further studies in traumatic shock? Scope of further study. I think they're asking something really regarding the research in the traumatic shock. Okay, plenty of research is possible in this field. You can go back and refer your Tintinelli and the other books. Okay, see your area of practice. Okay, and accordingly you can go ahead and do the research as per UK protocol 250 ml bowl or something. Okay. Okay, thank you, sir. That was a nice opportunity to speak on this platform. I think the questions are continuously coming. Can we answer these questions now? If fresh whole blood is it available better than 1:1 resuscitation, sir? Okay. Yeah. If fresh whole blood is available, that might be administered, but most of the blood banks these days, they don't keep fresh whole blood. Okay. Or as soon as the blood is collected, it is divided into various components and stored and it is stored. Okay. In the modern blood banks, the fresh whole blood is not stored. When it is available, you might use it. Thank you. We'll close the questions here.
Yes, sir. I think we can wrap up the webinar today.
Yes, sir.
Thank you all the attendees for attending the webinar. Thank you. Good evening.
Yes, sir. Thank you, sir.